Okay, vulval cancer. So generally the age at which the vulval cancer occurs is more than 65 years. So 80% of the patients have more than 65 years of age, and in UK instance is 1:293. And 80% of vulval cancers are squamous cell carcinoma, and generally they are unifocal at once and only they'll occur, and mainly on the labia majora. Lichen sclerosis converting into vulval cancer is mainly the differentiating win is 30%. Okay, 20 to 30% of vulval cancers associated with HPV, mainly the high risk 16, 13, and 31, 16, 18, and 31. HPV infection generally occurs in young, and there are multifocal vulval cancer lesions are seen. And in case of you are strongly suspecting the vulval cancer, then refer her to cancer center. Okay, diagnosis is incisional biopsy, not excision. Incisional biopsy is done where the skin and the lesion is cut. At least 1 mm depth is required for that biopsy tissue. Spread is seen in case of to the lymph nodes, mainly the inguinal lymph nodes, both superficial and deep, then femoral, then external iliac, then coming to hematogenous spread. Staging, it is 1, 2, 3, 4. 1 is again 1A, 1B. 1A is less than or equal to 2 cm, and depth is also less than or equal to 1 mm depth. Where stage 1B is more than 2 cm, more than 1 mm depth. Stage 2 is urethra, vagina, and anus lower 1/3 are involved. Stage 3, where the inguinal lymph nodes are positive. Stage 3 again is divided into 3A, 3B, 3C. 3A is again 3A1, where the lesion is one lymph node is seen in 3A1. One lymph node is seen, and that is also more than 5 mm in size. Whereas 3A2 is 1 to 2 lymph nodes are seen and less than 5 mm in depth, size. Next, coming to this stage 3B. B is also having B1 and B2. B1 is 1 to 2 lymph nodes which are more than 5 mm in size, whereas B2 is more than 3 lymph nodes which are less than 5 mm in size. Okay, stage 3 is extra capsular spread is seen. Coming to stage 4, in this urethra vagina lower 1/3 2/3 are involved, and again the stage 4 is divided into A1, A2 and B. A1 is urethra vagina and all pelvic lymph nodes are present, whereas 2 is inguinal lymph nodes are present, and B is pelvic lymph nodes plus distant metastasis. Okay, pelvic lymph nodes plus distant metastasis. So generally we'll do a surgery known as radical wide local excision, in which we also followed by CT scan. PET CT should be done before this surgery. Okay, before doing this radical wide local excision with chemotherapy. Management is in fixed histopathology specimen at least 8 mm depth should be present, whereas in case of fresh specimen 20 mm depth is required. Okay, a deep margin up to inferior fascia of the urogenital diaphragm is cut. Superficial inguinal lymph nodes and deep femoral lymph nodes are taken. Treatment for 1A is less than 2 or 1 mm depth. For that we will go for radical wide local excision, and lymph node dissection is not done. Whereas for stage 1B, where is 2 cm and more than 2 cm, more than 1 mm depth, radical wide local excision plus lymph node dissection is done. And if the lateral lymph nodes are present, then lymph node dissection is done. If it is positive, then contralateral lymph node dissection is done. If it is medial, then directly we'll go for bilateral lymph node dissection. Radiotherapy is given only if lymph nodes are positive, then radiotherapy is given on that side. Coming to sentinel lymph node biopsy. Sentinel lymph node biopsy is done in vulval cancer in 7 indications. 1, the lesion should be unifocal, it should be squamous cell carcinoma, and it should be the distance diameter is less than 4 cm, and stromal invasion is more than 1 mm stromal depth in invasion should be present, and lymph node should be negative. Okay, sentinel lymph node biopsy, lymph nodes negative, then you'll go for sentinel lymph node biopsy. Then safety should be ensured, and that person should follow up. Okay, mainly in 1 year she should follow up at least 2 to 3 months. Okay, she should follow in that way, then only we should go for sentinel lymph node biopsy. Okay, next part I'll cover in next video. Thank you.